There is a window of time, roughly between 6 in the morning and noon, when stroke rates in older adults climb measurably higher than at any other point in the day. Neurologists have known this for decades. What took longer to understand was why. And part of the answer, it turns out, has nothing to do with medications, stress, or what you ate the night before. Part of it has to do with how your body was positioned while you slept. Sleep is not a passive state. For the hours your conscious mind is quiet, your brain is running an active maintenance cycle, clearing cellular waste, regulating pressure, managing blood flow to regions that spent the day working hard. That cycle has requirements. One of them, which most people are never told about, is positional. The angle of your neck, the weight on your chest, the orientation of your spine. These determine whether the vessels feeding your brain stay open, whether your airway remains unobstructed, and whether a critical cleaning system inside the brain can do its job at all. Most people choose a sleeping position the way they chose their first mattress, based on comfort and long habit. For a body under 40, a neurologist will tell you that is largely fine. For a body over 60, it deserves a second look. To be precise about what we mean by risk, sleeping positions do not cause strokes the way a blood clot does. What they do is create conditions: a compressed airway, a restricted vessel, a pressure system that cannot regulate itself properly, that raise the likelihood of a vascular event. A stroke, or a TIA, what some people call a mini-stroke, in people who already carry risk factors. That distinction matters, and any honest neurologist will draw it for you. The good news is that the adjustments that reduce those conditions are not dramatic. A pillow repositioned, a side changed, one long-standing habit reconsidered. Neurologists working in Japan's stroke medicine centers, where stroke and brain vessel disease has been studied more rigorously than almost anywhere on Earth, have spent years documenting the relationship between overnight body position and vascular outcomes in older adults. What they have observed about nighttime physiology is quietly reshaping how preventive neurology approaches the bedroom. Before we move into the full list, I want to flag one thing I am saving for the end. Researchers studying the brain's overnight waste removal system, a network of channels that flushes toxic proteins from brain tissue during sleep, found that your sleeping position directly controls how efficiently that system operates. When it cannot work properly, those proteins begin accumulating in the walls of blood vessels. The full study and what it means for you is coming at the end of this video. Tell me in the comments, how old are you and where in the world are you watching from? Now let's get into it. Position 1, flat on your back, the airway problem. The most common sleeping position in the Western world is also the one that creates the most consistent problems for older adults with any degree of vascular risk. Lying flat on your back sounds neutral. Anatomically, it is not. When you lie flat without adequate support under the neck, the soft tissue at the back of the throat, which has already lost some of the muscle tone it had at 40, is pulled downward by gravity. The airway narrows. Breathing becomes labored. In many people, it stops briefly and restarts, a pattern called obstructive sleep apnea, meaning the airway collapses intermittently and cuts off oxygen flow. Each episode triggers a small surge in blood pressure as the body fights to reopen the airway. In a person with healthy vessels, this is manageable. In a person whose vessels have already accumulated plaque or stiffened with age, repeated overnight pressure spikes are not a neutral event. Think about what that means over months and years. Not one bad night, hundreds of them, each one nudging a system that is already working harder than it should. Sleep apnea is far more common in adults over 60 than most people realize, and a significant number of those affected have no idea it is happening. The adjustment here is specific. If back sleeping is your strong preference and changing it entirely feels unrealistic, the minimum intervention is elevation. Raising the head of the bed by 4 to 6 inches, not just adding a thick pillow which can kink the neck, keeps the airway at an angle that reduces collapse. A wedge pillow designed for this purpose does it more reliably than stacking. If you snore, wake unrested, or have been told you stop breathing at night, this applies to you directly. What comes next affects a different part of the vascular anatomy, not the airway, but the arteries themselves. Position 2, Face down, the hidden arterial pressure. Most people who sleep on their stomach do so because it feels safe and contained. The bed beneath them, nothing exposed. What they cannot feel is what is happening in their neck. The vertebral arteries, the two vessels that run upward through the bones of the cervical spine and supply blood directly to the brainstem and the back of the brain, travel through a narrow channel in those vertebrae. When the neck is rotated to one side, as it must be for a stomach sleeper to breathe, those channels compress slightly. For a few hours at a time, over many years, this structural pressure affects the blood supply to regions of the brain that govern balance, coordination, and the basic background functions the body runs without your involvement: heart rate, breathing rhythm, blood pressure regulation. Japanese rehabilitation physicians who work with older adults recovering from posterior strokes affecting the back of the brain, have documented stomach sleeping as a consistent feature in the histories of a disproportionate number of their patients. The relationship is not causal in a simple sense, but it is a pattern that appears too consistently to ignore. That distinction from the previous position is worth stating plainly. Flat back sleeping creates risk through airway collapse and intermittent oxygen loss, an on and off breathing problem. Prone sleeping creates risk through direct mechanical compression of the vertebral arteries, a structural problem that is present continuously every minute the position is held. Different pathways, same category of outcome. If stomach sleeping is deeply habitual, a body pillow along the side can make side sleeping feel more secure. Most people who make the switch report adjusting within 2 to 3 weeks. This third one shifts from position to something most people have never thought to question: the height of what is under your head. Position 3. Pillow height, the all-night angle. In Japan, the traditional makura, the sleeping pillow, was historically quite low and firm. Not for reasons of aesthetics or minimalism, but because generations of practical observation had established something that Western sleep culture largely ignored. The height of the pillow determines the angle of the cervical spine, and the angle of the cervical spine determines how freely blood moves through the vessels of the neck during the hours when you are not conscious to compensate. The carotid arteries run on either side of the neck and carry the majority of blood to the front of the brain. They are sensitive to sustained angle. A pillow that is too high pushes the chin toward the chest and places those vessels in mild but prolonged compression. Too flat and the head tips back, creating the opposite strain. In a healthy younger adult, neither extreme matters much. In an older adult whose vessels have less elasticity and whose blood already moves under greater resistance, 6 to 8 hours of suboptimal angle is a different matter entirely. The general guide is this: when lying on your side, the pillow should keep your head level with your spine, not tilted up, not drooping down. When lying on your back, there should be gentle support under the natural curve of the neck, not a stack that pushes the head forward. Memory foam contour pillows designed for cervical support do this reliably. They are worth the investment. Position and pillow work together, which is why the next section addresses what happens when you get both right but choose the wrong side. Position 4, the wrong side, right versus left. Side sleeping, as a category, is better for vascular health in older adults than either back or stomach sleeping. But not all sides are equal, and the difference between left and right is more significant than most people realize. When you sleep on your right side, your heart sits at an angle that places mild but sustained compression on the inferior vena cava, the large vein that runs up the right side of the spine and returns blood from the lower body back to the heart. That compression slightly reduces how efficiently the heart fills between beats. In a young, healthy adult with strong cardiac output, the body absorbs that reduction without difficulty. In an older adult with high blood pressure, a weakened heart muscle, or a history of atrial fibrillation, an irregular heart rhythm that is itself one of the leading causes of stroke, it adds a small but nightly load to a pump that is already working at reduced capacity. Night after night, month after month, that cumulative inefficiency matters. The point is not that sleeping on your right side will cause a stroke. The point is that it creates a set of conditions that a body carrying vascular risk does not need. The left side removes those conditions entirely. If you have no strong reason to prefer the right, the switch costs you nothing. What connects this to the next is not position, but timing. Specifically, what happens in the moment sleep ends. Position 5. The morning transition, rising abruptly from sleep. This is the moment when overnight physiology and waking physiology collide most dangerously. During sleep, blood pressure drops, heart rate slows. The vessels supplying the brain have been operating in a lower demand state for hours. When you stand immediately upon waking, as many older adults do, particularly those woken by an alarm, a noise, or a nighttime bathroom trip, the cardiovascular system is asked to shift from its overnight baseline to full upright function in seconds. The blood pressure change that results is abrupt. In people with healthy elastic vessels, the body adapts quickly. In people with stiffer vessels and higher baseline blood pressure, the adaptation lags, and during that gap, blood flow to the brain is temporarily reduced. Japanese stroke neurologists refer to this transition window as a period of particular vigilance. The guidance is simple. Before rising, pause. Sit on the edge of the bed for 60 to 90 seconds before standing. Let the cardiovascular system begin its upward adjustment while you are still low to the ground. This habit costs nothing. And for older adults prone to dizziness upon standing, that sudden lightheadedness that passes in a few seconds but can cause a fall, it makes a measurable difference. If nighttime bathroom trips are frequent, a low nightlight helps you orient without triggering full wakefulness. The goal is to slow the transition, not simply to be careful once you are already upright. The habit before our payoff is one that many older adults have adopted with the best of intentions, and which carries its own vascular trade-offs. Position 6. The recliner habit. Why the chair is not a bed. For older adults managing heart failure, severe acid reflux, or chronic back pain, sleeping in a recliner is sometimes a physician-recommended accommodation. In those cases, the elevation serves a real purpose. The concern arises when chair sleeping becomes a default, a long-term substitute for bed sleep driven by habit, comfort, or the slow disappearance of the expectation that lying flat should feel restful. Picture what happens inside the body. When you are significantly reclined rather than horizontal, blood pools in the lower extremities, the legs, the feet, because the heart must work against a greater gravitational load to push it back upward. In older adults with reduced vascular tone, that pooling raises the risk of clots forming in the deep veins of the legs. Those clots, if they dislodge, travel. In the most serious cases, they reach the lungs. And in people who have a small natural opening in the heart, present in roughly 1 in 4 adults, they can cross into the arterial circulation and move toward the brain. There is a second problem. Chair sleeping rarely produces the deep, sustained sleep stages the brain needs to run its overnight maintenance systems. The body senses postural instability and stays in lighter phases all night. This matters for reasons the final section will make fully clear. If a recliner has become your primary sleeping surface, the conversation worth having is with your physician to find out whether the underlying reason for it can be addressed and whether a properly supported elevated bed might serve the same purpose with fewer risks. Position 7. Left side down, the brain's cleaning window. Most people think of sleep as rest. Neurologists do not. They understand it as the only window the brain has to clean itself, and everything that follows in this section depends on that distinction. I want to pause before we get into the science here, because what I am about to describe sounds, on first hearing, like the kind of claim that belongs in a magazine headline rather than a neurology conversation. The idea that the specific side you sleep on could affect your stroke risk at the level of individual cells is not intuitive. So let me walk you through the mechanism first. Once you understand how it works, the research will make immediate sense. The brain is sealed inside the skull. It cannot flush waste the way other organs do, through the lymphatic system, the network of vessels that drains cellular debris from the body. The brain has its own version of that system, discovered only in the last 15 years. Scientists call it the glymphatic system, a combination of glial cells, the structural support cells of the brain, and lymphatic function. During deep sleep, those glial cells shrink slightly. The spaces between them expand. Cerebrospinal fluid, the clear liquid surrounding the brain and spinal cord, flows through those expanded spaces and sweeps out the waste that built up during the day. The primary targets of that sweep are two proteins, amyloid beta and tau. You may recognize those names. They are the same proteins associated with Alzheimer's disease. What most people are not told is that they also accumulate in the walls of blood vessels, not just brain tissue, and that accumulation is directly linked to stroke risk. Sleeping position controls how efficiently that sweep happens. Researchers conducting imaging studies on adults found that side sleeping produced significantly better glymphatic drainage than either back or stomach sleeping. And within side sleeping, the left side showed a consistent advantage. The glymphatic drainage pathways follow the body's natural asymmetry, and on the left side, gravity assists the flow rather than working against it. A clinical trial involving adults between 60 and 80 found that participants who shifted to consistent left-side sleeping over 8 weeks showed measurable reductions in fluid markers associated with amyloid accumulation. That matters because amyloid buildup in vessel walls is one of the known mechanisms behind a condition that weakens blood vessel walls in the brain and raises the risk of bleeding stroke. These are not small findings. It is worth noting one thing here. Japan has among the lowest stroke mortality rates of any country in the developed world, and left-side sleeping, supported by low, firm pillows that maintain cervical alignment, is significantly more common in Japanese sleep culture than in the West. No one has drawn a definitive causal line between those two facts, but neurologists who are aware of both do not consider it a coincidence. Now think about what it costs to do nothing, not dramatically, just quietly, year after year, a brain that cannot fully clean itself overnight, proteins accumulating in vessel walls, vessels that become progressively stiffer, narrower, more fragile. Until one morning, there is no warning and no second chance, no ability to drive yourself to the doctor's appointment, no energy to keep up with the grandchildren, no walking up the stairs without stopping. That is not a hypothetical. It is the pathway that stroke research has been documenting for decades, and the difference between that outcome and a different one may be as simple as which side you fall asleep on tonight. The practical instruction is straightforward. Sleep on your left side. Use a supportive pillow at the correct height so the neck stays aligned, and the carotid arteries are not compressed in the process. A pillow between the knees reduces hip strain and makes the position easier to hold through the night. If you wake on your back or your right side, simply return to the left. Consistency over weeks is what matters, not perfection on any single night. No medication, no equipment, no cost. So in summary, 6 things. Here is what each one does. Flat back, sleeping without proper support, narrows the airway and causes repeated overnight blood pressure spikes. Stomach sleeping compresses the arteries running through the neck vertebrae, the vessels feeding the back of the brain. Every minute the position is held. Pillow height controls the angle of the carotid arteries for the entire night. Too high or too low both create sustained strain. Right side sleeping adds compression to the heart's return circulation and can contribute to nighttime heart rhythm disruption. Rising abruptly forces a rapid pressure shift that temporarily reduces blood flow to the brain. 60 to 90 seconds on the edge of the bed before you stand is all it takes. Chair sleeping pools blood in the legs and blocks access to the deep sleep stages the brain's cleaning system requires. And left side sleeping is the position that gives that cleaning system its best chance to work, clearing the proteins that, over time, accumulate in vessel walls and raise the risk of stroke. Full details on pillows and sleep aids mentioned in this video are in the description below. Every one of these changes happens while you are already asleep, which means the only real decision is tonight. If this was useful, please share it with someone you care about, particularly anyone over 60 who has never had a conversation like this one. And tell me in the comments, which one surprised you most and which one will you act on first? I read every comment. I will see you in the next one.